You say anything about controlling the disease, you're for destroying people's livelihoods. And if you talk about the economy at all, then you must be against controlling the disease. Frankly, it's insane. Anybody who's seen this up front or who's dealt with it understands that the two go hand in hand together.
We're talking today with David DeRalph, who's the Executive Director of Kokua Kalihi Valley, one of the most important community health centers in the state, and Jonathan Dworkin, an infectious disease specialist, a physician affiliated with Queens. Both of them have been involved in treating COVID patients, advocating for COVID patients, and in the public health response. And we're going to be talking today about the clinical experience of treating patients in Hawaii with COVID-19, as well as the public health response, and some recommendations that physicians and public health experts have on how the state should be reopening tourism. Aloha, Jonathan and David, thank you so much for joining us today.
Thank you very much for having us.
Thank you.
We haven't had so many COVID cases in Hawaii, but Jonathan, you've seen a number of them. You know, what was that like at the beginning, knowing those COVID patients were coming and then having them actually arrive?
There was a lot of confusion initially. We were paying attention to this disease as it exited China. We were paying attention to our tourism numbers. We knew that it was coming our way. We knew it was a matter of time before it arrived. But we didn't have access to testing initially. And none of us, of course, had experience treating it. So our familiarity with the syndrome clinically was non-existent. So you can imagine the sort of nerves that everybody was feeling, particularly during the month of February, the month of March, when we knew this thing was coming at us. We were looking around the world. We saw that it had hit some places very hard, and we weren't sure how hard it was going to hit us. We weren't sure how our system would respond to it. And the additional wrinkle, the thing that really set us over the edge, was that we couldn't see it. We didn't have reliable and available diagnostic tests. We were blind going into this boxing match with a pathogen that we haven't encountered before.
Did you start having suspected cases before you had actual cases?
Yeah, we did. We had a number of suspect cases, and there were different flavors of that experience. There were the people who had non-specific symptoms but could have had it, and we now know that this is a disease that can prevent with very mild symptoms in some patients. So, ideally we would have tested those people, but we weren't able to. Then there were people who really seemed like they probably had it. They had radiographic findings and other findings that really suggested it, but they did not meet our criteria, our very limited and narrow criteria at the time for testing, so we couldn't get them tested. And we just gave them the best advice we could. So it was a really chaotic situation. We began to develop lab capacity within the Queens system pretty much as soon as we were allowed to do so. And once the diagnostic testing came online, it really improved our ability to sort of be aware of what was going on. Our situational awareness went way up. And then we had a much clearer picture of what we were dealing with.
How do you even begin to treat illness for which there are no protocols? Were you kind of at night trying to learn on the fly? Like I read about doctors turning to proning or changing their criteria for ventilator use as time went on.
Yeah, there was a lot of that. There was a lot of learning on the fly. I think most of us sort of went into a deep dive with the medical literature. There were a lot of things being posted online even before peer review. So we were doing almost like live online peer review for each other, looking at things that were being posted on websites. Most of us were reading multiple articles a day, trying to get a handle on what the clinical syndrome looked like.
So many healthcare providers, as many as 500,000 now by the latest tally I saw, have been infected. How did you manage treatment, intubation, these quite perilous procedures with yourself and staff while trying to provide good care, but also trying to protect yourselves?
Well, we have infection control protocols for trying to prevent transmission in the hospital. Now, obviously, when it's difficult to test people, as it was early on, it's difficult to know who to apply those protocols to. So, it's not a surprise to me that we've seen a lot of transmission in healthcare settings. A lot of the problems is correctly identifying who's likely to have the disease. Once everybody knows that a person is COVID, we tend to be very aggressive in terms of using, protective equipment. But we had two problems early on. We had the problem of lack of diagnostic testing, and then we also had the acute shortage in protective equipment. So both those things were happening simultaneously. Frankly, I think we got lucky. If we had been hit a week or two earlier, we might not have done as well. And there were other facilities that didn't do as well in other parts of the country, obviously. So it's an ongoing issue. It's a little bit better now that we have improved diagnostic testing and we're not as short on all the supplies.
Sure. As far as I know, we've had kind of three main clusters, at least that I know of. One, of course, at Maui Memorial Hospital, another on the Big Island with a couple of McDonald's, and a small cluster that's active now. I was wondering, David, if you could tell us a little bit about what you think we've learned from these clusters and what special challenges the cluster that you've been involved with presents.
Yeah, I think early on at the first COVID task force meeting called by the Lieutenant Governor, I, using my 5 minutes of time to speak, raised the concern that I felt that it was likely, given intense crowding and the necessity of people to go to work as frontline workers, that at some point in time that this epidemic would begin to manifest itself most dangerously within public housing, of course, along with perhaps long-term care facilities and homeless shelters, those being the three highest risk populations. It's certainly been the case around the country, as we've seen, actually around the world. We first, I think the first real wake-up call for all of us in that regard was Singapore. We were all watching Singapore as a model country. They had very low numbers of cases every day, I think on the order of maybe 10 to 20 cases on many days. They had very few deaths. And suddenly they were up to 1,500 cases a day. And it was all because they had ignored their most vulnerable communities, communities who historically had not had good access to care and who lived in very crowded conditions. So of course, the community I work in, that is also the case. These are people who both live in very, very crowded homes. I think the record for me is I've had families who 21 individuals share a one-bedroom apartment, actually sleeping in shifts. And most of us who live in Hawaii can't quite imagine crowding that intense, but it exists right here in our midst. And sure enough, we now know that, in fact, given the nature of the work that these communities are engaged in, these are people who don't have the luxury, by and large, of staying home. They won't be getting a check from the federal government. They're probably not going to be, for a variety of reasons, qualified for unemployment insurance. They're going to work every day, and they're coming home to a very crowded home, oftentimes with elderly parents, and almost 100% of the time with individuals in the home who have chronic diseases that put them at risk of morbidity and mortality from this infection, principally diabetes, hypertension, obesity, and the like. So we weren't surprised. We were obviously very worried. This is an enormous challenge for all of us. There's a lot of fear around testing. Unlike most of the United States, where the news stories have been, I want to get tested, and testing was unavailable. In this community, I don't want to get tested is the norm. Please don't ask me to be tested.
Because of distrust of authorities within the communities that you're dealing with? Is that the accounts for the reticence?
I think there is certainly distrust there. I think that there is a huge stigma associated with being identified as being infected. You are the person who brought infection into our community. So we have a real uphill battle there to work with our community, to work with trusted leaders in the community. Oftentimes those are the ministers, to gain that trust, so that the community is more amenable to not just being tested. We also have to, I think with testing has to come support. People have to know that if they're found out that they're infected, we oftentimes throw the words quarantine and isolation around casually without really thinking about what that means for people. If you're a Native Hawaiian person, your family history of that might be Hansen's disease and families being torn apart. Those memories are not that old that people have forgotten them. They have not forgotten those. This is an area where we have to tread very carefully, and we have to make it absolutely clear that with a positive test comes a supportive community. That support might be meals for the family. It might be finding a safe place for the person to isolate. It might be medical care. It might be finding resources to keep the family afloat while that person who's the worker doesn't go to work. Because around the country now, we've seen examples where low income workers in long-term care facilities who were infected continued to work, and maybe worked in multiple facilities, some of them holding down 2 or 3 jobs. And people would say, well, how in the world would they do that? And of course, not thinking, well, if they didn't do that, how were they going to support their family? So we really have to, the mantra really needs to be changed from test, trace, and quarantine to test, trace, quarantine, and support.
And have you been able to take advantage of emergency state or city resources in terms of, hotel space for voluntary isolation for those who want to take advantage of it, or emergency food support, or any of these kind of issues? Or have you had to more kind of cobble together that support on the fly as best you can?
No, I would say there's been a tremendous outpouring of support, particularly from the private philanthropic community immediately. I was really impressed with how fast our local philanthropic community were on this and coming to us and saying, what do you guys need? What are you hearing? What's the biggest need in the community right now? And for us, the immediate need was we provide care management services to about 1,600 home based elders, people who are aging in place at home, who are at risk of social isolation, lack of food, inability to get their medicines, and of course, if they get this illness, very high mortality. We were tremendously fortunate to have some resources come our way right away so that we could begin bringing meals, bringing food baskets, providing medications, at the doorstep telehealth visits, that kind of stuff was our highest priority, and we're really thankful. More recently, the mayor of Honolulu has been set up a program to help us increase our testing capacity, and brought money our way to really beef up our ability to offer testing in the community, and that's been really helpful.
Both on the treatment side and on the public health side, do you feel like now at the beginning of June, we are better positioned to deal with this cluster and future clusters than we were, say, in March?
I can't answer that question with a great deal of confidence. I would love to be able to answer your question and say, absolutely, the systems are in place, they're rock solid. If this epidemic grows again in Hawaii, we'll be there. I know that there's enough contact tracers and enough testing capacity and enough logistical support to carry out investigations for multiple clusters simultaneously. I don't have that kind of confidence to say that today. I think it's really incumbent upon all of us to understand what we're talking about here, because in general, people look at the numbers in Hawaii and they say, well, we must have this thing nailed down. We seem to have done something tremendously well. And yes, indeed, we did do some things tremendously well. Number one, we shut down the state to tourism and kept out lots of infections. Because remember, the vast majority of our infections were imported by local residents returning from the mainland and tourists coming here. Second thing was we locked down. Very costly process, estimated, I think, at about $3 billion a month for the state to do, but it clearly made a huge difference. What I'm less certain of is whether or not all of our policies around contact tracing and quarantine and isolation have been as effective.
Jonathan, on the treatment side, do you feel like you're, even though the research is still ongoing and not at all finalized, do you feel like you're better prepared to properly and successfully treat someone who's seriously ill with COVID at this point than say you were a couple of months ago, or are you still a little bit shooting in the dark?
It's still early going in terms of treatment. You know, the only drug that's been shown to have a benefit in a good randomized controlled trial is remdesivir, and that trial, as you may be aware, it was terminated a little bit early before the mortality benefit of the drug was clearly demonstrated. It does seem to have some positive benefit, but there's also not a lot of remdesivir around at the moment. So from a therapeutic side of things, you know, it's still mostly supportive care. I think that's important for people to understand. The supportive care is pretty good, and we're gaining experience with that now. But as far as we know, this is still an infection with a significant fatality rate, particularly in people with underlying comorbidities and in elderly people.
What's your sense on the public health side of whether we have had such success relative to other states on the continent? Do you think that's a matter of relatively early steps we took, or did we just get lucky?
I mean, I think we have success, and I'm proud of the success we've had, but we also have to be clear-eyed about what we did. It was all relatively heavy-handed. You know, we basically locked down the state and stopped letting people come in. And, you know, that worked. That worked pretty well. And I think it was also combined with a healthy dose of luck. We had more important cases in February. Before we had done that, we probably would have had a bigger epidemic. And as it was, we had an epidemic of about 600 patients, which was, you know, when we were in the middle of it, fairly significant. So we did some things well, but the issue that I think David raises is that as we open up, we want to be able to remain open. We want to avoid the sort of economic cataclysm that's coming our way from being locked down for a long time. We need to be able to open, and we need to be able to stay open. And in order to do that, we need really rigorous public health infrastructure. You know, we need the ability to test rapidly. We need the ability to contact trace at scale and quickly. I think we need a better system for voluntary centralized quarantine. And what I mean by that is, you know, if someone tests positive, we need to be able to get them out of their house if they're in a multi-generational house, or at the very least get their relatives into the house, and in a way that provides, you know, good quality care of the kind that David was mentioning. So this is
these charges, by the way, I like to tell everyone, all of these kinds of charges, renting hotel rooms for people, getting them meals, like all of those can be charged to the federal government under the CARES Act.
But what's required of us, I think, is a system of organization to do that.
Yeah.
And I'm not convinced that we've stood that up adequately.
Well, both of you have been involved, I know, in working with other physicians and healthcare providers in drafting your own recommendations to the state on reopening tourism in particular safely. I guess my first question is, you know, why did you feel the need to organize independently to kind of put these views forward?
Yeah, I mean, I think Jonathan and I met up at one of the first task force meetings called by the Lieutenant Governor. And I suspect both of us came away from that meeting. I mean, well, I'll speak personally and Jonathan can answer for himself. I would say I went into that meeting sort of assuming I would go in and I would see a highly organized, disciplined group of people who were ready to come together, had good plans to implement, or at least a process whereby we could coalesce around a set of ideas and implement them. And I was pretty dismayed at the first meeting to see that we were far, far from that. So both of us initially started out I think sort of unofficially as part of the HIEMA process, for whatever reason, didn't continue along that path. We both said to each other, well, it looks like we're just going to have to do this on our own. And we were surrounded by other people who were saying the same thing. And I think in a way, as it turns out with these epidemics, the actions of individuals and families and communities are probably far more important in the big scheme of things than the government. And in particular, when you have a federal government system that has failed us miserably, including a once very prestigious institution, the Centers for Disease Control, that the entire world looked up to for answers for these kind of situations, and which now is sort of the laughingstock of the world, altering their approaches to this weekly, not based on good science, but based on the politics. And so that has really left a huge vacuum. I think that vacuum has affected Hawaii. I think that means it's incumbent upon us to all respond. I think there's many of us here who recognize now that we all have a role to play in this. We all shouldn't be afraid to play a role. We should all learn to speak up. We should all learn to help out. We should all say, what am I good at and how can I help out? That in the long run, however we come through this epidemic, that is going to be something that will strengthen Hawaii tremendously.
Yeah, it's been heartening to see how Hawaii residents have come together at great sacrifice to turn back this disease. There's a lot more cooperation in Hawaii than there has been elsewhere. But when it comes to tourism, that is an area that it's hard for individuals to regulate. Inter-island travel will be opening with temperature checks, which have been used in some other infectious disease outbreaks. And I'm wondering if you think that's going to be a good model for opening travel internationally and domestically, or if we're going to need something more aggressive and specifically tailored to the presentation of this disease.
We don't think that a temperature screening system is going to be adequate to protect the residents of Hawaii. And that's based on the performance of those types of systems in other settings. So, to be clear, going forward, we're going to have to build this as we go. And nobody knows exactly what the perfect system is going to look like. But we do have adequate evidence from temperature screening systems in other places to know that it's probably going to miss the majority of the patients. A lot of people are either asymptomatic or they're pre-symptomatic at the time that they're spreading the infection around. People can also fool temperature screening by taking antipyretic medicines that lower body temperature. So if we are entrusting the safety of the population of Hawaii on such a system, I think what we're engaging in is a kind of airport theater that's going to be designed to make people look busy and look like they're doing something, not actually be effective. And what's particularly alarming to me is that we're proceeding down this pathway without having brought in some of the top people in the state to help design the system. So I think the most basic purpose of our letter is to say, stop, don't do this. Don't go down this pathway by which you're introducing infection into the state after everything that we've gone through without having a really good conversation with some of the top people in the field to figure out what's the best way to do this in a way that actually protects the people of the state.
And
yeah, I just want to add to what Jonathan said there. I mean, I think sometimes when we have this conversation about incoming tourists, people think, oh, so you're not concerned about the impact of the loss of tourism to our state economy.
Right.
And it's just the opposite. In fact, we're deeply worried about it. And we feel that we have an opportunity to do this well. And if we don't do it well, neither the economy nor the health of the residents of Hawaii will be served.
Hawaii can be a safe place, which is a tremendous advantage in the global tourist marketplace. But we can't be a safe place unless we actually are a safe place.
Yep, and particularly from where I sit, in a community where the majority of people who are employed in the hotel industry or serving the tourist industry in other capacities. Those people are frontline. I get to see them as my patients on a regular basis. And what they tell me is safety is their first priority. They are suffering economically right now. They know what that feels like. And yet safety is their first priority. We need to listen to those frontline workers here first and foremost. We shouldn't be guided by the voices of hedge fund managers from New York City who are not here in Hawaii on the ground.
To reinforce your point, at least my understanding is the steps that you are recommending do not necessarily require a great period of extension of the quarantine, rather the immediate implementation of technologies that are already available. So Jonathan, what do you think, what are your recommendations to start off?
Yes, so the whole purpose of our letter was to articulate how to get people out of the quarantine so that we can open up the economy. So, the sort of irresponsible thing to do would just to drop it without any real system in place, or with a purely theatrical system in place. And then what I suspect would happen is we would reintroduce cases. People would realize it's not very safe. And then that would have deleterious impacts both on the health and the economy. So what we're trying to articulate is, how do we do this in a way that's smart? How do we do it in a way that actually makes the system safe so that people don't just feel safe because they've got some PR messaging that they should feel safe. They feel safe because they actually aren't safe. And what we think that looks like is some sort of test-based surveillance. At a minimum, we want to have people tested before they board the plane. And then we want some sort of follow-up after they arrive. And there's a lot of technical details that need to be worked out on what exactly that would look like. We don't reject entirely some sort of symptom-based screening, but we think that should be part of this larger process, not instead of it. So there might be an additional step when they arrive. Ideally, it would involve a second test. Work out the logistics of that. And what that would allow people to do is exit from the 14-day quarantine and enjoy being in Hawaii. And people in Hawaii would be able to feel good interacting with them, knowing that they've been tested.
This same question is being deliberated at governments around the world. 140 countries at least are trying to implement some version of this. Most countries around the world, if you look right now, the vast majority, I think 98%, are still locked down to having tourists come in. They require mandatory 14-day quarantines for anyone who wants to enter their country, or they don't allow anyone to enter their country. There's only a small handful that plan to open up in the next couple of weeks. I think Iceland is the first one. Iceland is doing a test-based strategy like we're recommending. I think we'll have some data over the course of the next 4 to 6 weeks that will show us which strategy works, what happens with the various strategies, how do you implement it. We're not doing this in isolation. That's the good news here. There's a lot of other smart people around the world trying to figure out this exact same question. Jonathan, I, and the rest of our team certainly don't have the answers here. What we're calling for is, let's get the right group of people together to sort of figure out what is the best way to go forward.
We don't have to wait for a perfect solution because the two alternatives, either letting people in without testing, which could lead to an eruption of multiple clusters that could be catastrophic, as we've seen elsewhere, on the one hand, or continuing to shut down the economy, which is destroying people's lives in different ways and costing the state billions of dollars a month. Like, there's a lot of room for imperfect solutions between those as we go forward.
That's right. And in order to hit, I think, the right balance there, we need to reject this way of formulating the problem that puts people either pro-health or pro-economy. There's a politically very supercharged debate playing out on the mainland in which, if you say anything about controlling the disease, you're for destroying people's livelihoods. And if you talk about the economy at all, then you must be against controlling the disease. Frankly, it's insane. Anybody who's seen this up front or who's dealt with it understands that the two go hand in hand together. And, we have an opportunity in Hawaii to have a better and healthier debate about this than is what's playing out on the mainland. So, that's a big part of what we want to do, is create space for that to happen and then get at a result that actually works.
How fast could a pre-flight testing or post-arrival checkup system, do you think, be implemented?
It would take a few weeks to get this figured out. I'm curious to hear what David thinks about it, but there are a number of technical problems that you have to solve. What tests count as valid tests? How do you validate them? If you're going to set up post-travel testing, that's probably a public-private partnership of some kind that needs to be established. and then we got to see how it's working, troubleshoot it. It's not going to be perfect.
Yeah, no, I think the logistics of this is probably the single biggest hurdle. I think testing capacity around the country is growing rapidly. I think there still are questions around the best tests that could be done cost effectively and rapidly. But the amount of data that's accumulating about that is, that body of data is growing rapidly every day. Literally, we're learning more about this illness every day. And over the course of the next few weeks, I think we'll have a pretty good idea of what tests work and who's going to be. You see already, for example, CVS talking about drive-through testing at all the CVS locations in the country. You definitely want to have something that's widely available that people can easily access. Then you have to have a system in place at the airport to check this kind of documentation. I think, probably some sort of public-private partnership here makes the most sense to rapidly expand it. I don't think, our government agencies have demonstrated the ability to pivot really rapidly like that to implement something like this. Now, fortunately, we're not looking at 30,000 tourists a day coming through Hawaii over the course of the next few months, like we saw in 2019. We're probably looking at something like 6,000 a day. The numbers be, in a range where you could pretty easily imagine standing up a testing infrastructure to deliver that volume of tests. I think other places around the world are doing this. I think we should watch carefully how they're doing it and learn from them. I don't think we have to reinvent the wheel here. I think we should be in close communication with the governments of Iceland and New Zealand, Australia, Hong Kong, to see how are they doing this.
As a final question, of course it is wonderful that Hawaii has not experienced the surge that other places have, being though that we remain vulnerable in that only a tiny portion of the state has had any kind of contact with this disease. Besides a dramatic ramp up of the testing with regard to tourism, are there any other steps that you think are most urgent that the state ought to take that perhaps are not being taken yet?
I think this gets back to the first letter that David and I wrote, which was really focused just on the public health infrastructure itself. That includes testing, but it also includes the expansion of contact tracing, setting up a system of voluntary centralized quarantines in a lot of crowded housing if necessary. And these would be people who are worried about infecting their relatives and do so voluntarily. We're not talking about forcing people into quarantine. That's never even been an option. But I had patients who did not want to go home from the hospital because they knew that they were going to have a difficult time isolating from their families, and it was very difficult.
Yeah, who has a separate bathroom in Hawaii?
Exactly. So this is an ongoing issue, and I still have not seen that we've scaled up that level of public health infrastructure that we need to because it needs to be scalable. If we're having a cluster at some point that's, let's say, several hundred cases simultaneously, or even 1,000 or more cases, we're going to be stressed again. We're going to need to be able to do this, and we're going to need to be able to do it quickly.
I'm quite worried in particular about congregate living facilities for the elderly, just because the rates of death are so catastrophic on the continent. As many as half of deaths, it's starting to look like, are occurring in these types of facilities. And I know that one of them is affiliated with Kokua Kalihi Valley. Do you feel like there's enough surveillance testing of staff and residents and participants so that we can move beyond something besides just shutting these facilities to outsiders?
No, not yet. I think we're going to move that way. The biggest obstacle now is, initially it was a lack of tests, right? And so we really wanted to keep those tests available for people who were really sick and in the hospital. The testing availability is really good right now. We can expand the number of tests. There's still a lot of confusion around who should be tested. Given that we have an illness here that, ranges of asymptomatic infections have been as high as 80%, it's pretty clear to me that we need to spend less time asking that and just more time testing people, actually. I agree with Jonathan. We really, in order to move forward here, we're going to have to figure out how to be confident that we have adequate infrastructure. And I don't think we have adequate infrastructure. You know, we have a Department of Health that's probably been underfunded and underappreciated for years. We're asking them to move into an environment here that requires really rapid decision making, rapid capacity building, and has historically, as I said, looked to the Centers for Disease Control, the CDC, for leadership. That leadership has been absent, and I think they've been doing their best. And we all just want to know, is their best good enough right now? We want it to be good enough. We all have a role to play in making sure it's good enough.
Well, thank you very much for joining us, doctors. Take care of yourself and your staff and your patients. And I appreciate the work you're trying to do to keep Hawaii safe. Take care. Aloha.
Thank you very much. Aloha.
Thanks for having me.